once again welcome back. In this part of our today's video lecture, I'm going to talk about three important concepts. Firstly, I'm going to talk about cell membrane active transportation, okay, shortly. Secondly, I'm going to talk about the structure and functions of sodium potassium pump, its mechanism of action, and also its regulation, okay. And in third part of this video, I'm going to talk about an important class of drugs which affect this sodium potassium pump, okay. And as a group they are called Digitalis, or its types, for example digoxin or digitoxin, okay. I'll talk about the mechanism of action of Digitalis, the origin of this word, and then I'm going to talk about its usage, its adverse effects, and or its contraindication, and its toxicity and treatment of its toxicity. So let's get started. Firstly, I'm going to talk about active cell membrane transportation. As you know from previous part that we have two types of cell membrane transportation: active and passive. In active cell membrane transportation, we use energy or ATP. This is a type of biological energy. And in active cell membrane transportation, we move substances from low concentration gradient to high concentration gradient. What does it mean? For example, from this area of low concentration gradient, we move substances to this area of high concentration gradient by the power of ATP, by the force of ATP. For example, as you know from previous lecture, we have a lot of sodium in outside of the cell, and it's about 140 millimoles per liter. And we have more potassium inside of the cell, which is equal around 140 millimole per liter. So inside we have more potassium and outside we have more sodium. So now here is a pump. This pump is called sodium potassium pump, sodium potassium pump, or sodium potassium ATPs. What is the difference between pump and channels? You know, in pumps we use energy, and by the power of energy we move some things, and in channels we don't use energy. For example, aquaporins, okay. Anyway, this is a sodium potassium pump. So now when this sodium potassium pump convert ATP to ADP, okay. So by the power of this energy, or by the power of this ATP, this pump moves these sodiums from the inside of the cell to the outside of the cell, and moves this potassium from the outside of the cell to the inside of the cell. So this movement was against the gradient. It means from the low concentration gradient to the high concentration gradient. What does it mean? It means what does mean by the concentration gradient? Concentration gradient means the difference between the amount of substances between two areas. Anyway, so this is the sodium potassium pump is a type of active pump or active cell membrane transportation. This one type, this type of active cell membrane transportation, which uses energy directly. Okay, this type of active cell membrane transportation is called primary active cell membrane transportation. Okay, we have another type of active cell membrane transportation which uses energy indirectly. Okay, in this type of active cell membrane transportation is called secondary. This type is called secondary active transportation. Let me give you an example. For example, this is a pump. Okay, this pump is called sodium calcium exchanger. This is called sodium calcium exchanger. Why? Because it exchanges calcium and sodium. Like what? Let me give you an example. This is sodium. We have more concentration gradient of sodium outside of the cell than inside of the cell. So in secondary active cell membrane transportation, always two substances move from one area to another area. Okay, for example, this is sodium. One substance should be moved from the high concentration gradient to the low. For example, this is sodium. Sodium will be moved from the high concentration gradient to the low concentration gradient, and another substance is moved from the low concentration gradient to the high concentration gradient. For example, we have a lot of calcium outside of the cell. So this calcium is moving by this pump from the low concentration gradient to high concentration gradient. Why? Because sodium is more outside of the cell. Sodium says for this calcium that, my brother, I'm going to inside of the cell. Okay, I will go to the inside of the cell and I will bring you outside of the cell by my power. Okay, so this type of pump is called secondary active transportation. Why? Because it uses ATP indirectly. What does it mean by indirectly? Let me clarify this. You see, we didn't use any type of ATP here, but be careful here. This sodium potassium pump, the function of sodium potassium pump is that it pumps free sodium from the inside of the cell to the outside of the cell. When it pumps sodium from the inside to the outside of the cell, so it causes, the sodium potassium pump causes low concentration gradient of sodium inside of the cell. So because sodium is less inside of the cell, so this sodium comes from the high concentration to the low concentration. Okay, and by the help of this sodium, calcium will go out. If I block this pump, now see it, if I block this pump by some drug that later I will explain, this drug is digoxin. Okay, if I block this pump, so this pump can't excrete this sodium outside of the cell, can't move this sodium out from the inside of the cell to the outside of the cell. So concentration gradient of sodium goes up here. Okay, when it goes up here, so this sodium can't go inside of the cell. Why? Because previously it goes from the high concentration to the low concentration gradient, but now the concentration gradient inside is not low, it's more. So this sodium can't go inside. If it can't go inside, so this calcium can't excrete outside. It can't be pumped outside by this pump. Okay, so that's why we call it that this is secondary active transportation. It uses ATP or energy indirectly. Okay, we have I said you before that always we move two things from inside of the cell to the out, or from the outside to the inside by secondary active transportation. But there is two terms. One term is called symporters, another term is called antiporters. So what does it mean? let me clarify it. If one substance go from the outside to the in and one goes from the inside to the outside, okay, this type of secondary active transportation is called antiporters, okay, against each other, okay. If or counter transportation if both substances goes from the outside to the inside or from the inside to the outside. For example, here is an example of for example, this is iodide, and it goes inside to the cell with it. For example, also goes inside of the cell, or other pumps, other examples. And here that both substances goes from outside to the inside or from the inside to the outside. So this type of transportation is called symporters or co-transporters. This was so important for our today's lecture. So now let me talk about the structure and function of this sodium potassium pump or this sodium potassium ATPase. Now let me talk about sodium potassium pump. First of all, why this is called sodium potassium pump? Because it pumps 3 sodiums from the inside of the cell to the outside of the cell, and 2 potassiums from the outside of the cell to the inside of the cell. That's why this is called sodium potassium pump. And this is also called sodium potassium ATPase. Why this is called sodium potassium ATPase? Because these types of pumps consist an enzyme which is called ATPase enzyme, and this ATPase enzyme break down the ATP into ADP, okay, and that's why this is called sodium potassium ATPase. And also this is a type of P type of channels or P type of pumps. Why this is called P type of pumps? Because when this pump works, it uses phosphate, okay, and due to this phosphate it works. That's why this is called P type. Okay, now let me talk about the mechanism of working of this pump, because this is not so simple like this. It's so complex. This pump is made of 3 domains. It's actually made of 2 domains, but in some cells it's made of 3 domains. It's made of alpha domain, and its alpha domains is about 10 times transmembrane proteins. It is passing the cell membrane 10 times, okay. So that's a 10 time transmembrane protein. And also it consists of a beta part which helps this alpha part to be stable. Actually alpha part is responsible for ATPase function, and also it's responsible for pumping of sodium and potassium, but beta part is responsible for stabilization of this alpha part. Sometimes it consists of gamma part, but it's not important here. Now let me talk about mechanism of action of this part. It has 2 steps, E1 step and E2 step. In E1 step, E stand for enzymatical change. In which step? In E1 also has some steps. In E1 step, in first step, it is sensitive, its affinity is for binding of potassium is so much. This is inside of the cell and this is outside of the cell. So from inside of the cell, it binds to sodium, not potassium, sodium, okay. It binds to sodium in which stage? In E1 and first stage, okay. And first stage, when it binds to sodium, now it also contains ATP. It also contains ATP. So, and even step 1 is its affinity is more for sodium, plus it contains ATP. And even in second step, in which step? In second step, this door is occluded. This door is closed. Why? Because it doesn't want to these sodium fall back into the cell. Okay, and when it blocks these sodiums, this step is called occluded step plus ATP. Here also I have ATP. So in step 2, it's in occluded state plus its door is closed plus I have ATP. Okay, and this step, in third step of this event stage, from this step 2 to 3, from this time to this time, it means from step 2 to step 3, it converts ADP, it converts ADP, it converts ATP to ADP. Okay, and now in this step 3, I am in occluded state, number 1. Number 2, I have ADP. Number 3, I have phosphate. Okay, till now I have phosphate. But now, in this step from 3 to 4, in which step? In this step from 3 to 4, from 3 to 4 in this stage, this pump is losing ADP. When I lose ADP, so I'm going from E1 stage to E2 stage. From E1 stage to E2 stage. And now in E2 stage, for example, this is first stage of E2. In this first stage of E2, its affinity for binding sodium is now less. It loses sodium to the outside of the cell. Okay, and now in this first step of E2, the affinity for potassium is more. Now in this second step, of this E2, here, the affinity for potassium is more. Okay, now 2 potassium will be binded here. Okay, and when 2 potassium is binded here, now this pump has 2 potassium plus phosphate. Okay, now in this step 3 of E2 stage. Okay, in step 3 of E2 stage, now this pump is changed to an occluded stage. Okay, and now this pump has phosphate plus occluded stage. Okay, now for in this stage 4 of this E2, it means from stage 3 to 4. Okay, it loses phosphate. Okay, when it releases this phosphate, so now in stage, now in which stage? In stage 4 to 5. In which stage? In stage 4 to 5. ATP will be binded here. In this stage from 4 to 5, ATP will be binded here. And when ATP binds here, it goes to conformational change once again to E1 stage. It goes to conformational change once again to E1 stage. And now affinity of this pump is for potassium is less, so it will lose 2 potassium, and affinity for sodium is now more, and it's ready to get 3 more sodium for next cycle. So this cycle was actually the cycle and steps of sodium potassium pump. Now there are some factors that enhance the functions of sodium potassium pump. For example, the first thing that enhances the sodium potassium pump activity is insulin. Okay, as you know, for example, why? Because when glucose, this is a glucose, here is a pump, here is a pump, it has two domains. One domain is for glucose and one domain is for sodium. Okay, now this sodium from the high, for example, I'll write it here that this is glucose and this is sodium. Now this sodium from high concentration gradient to low concentration goes inside of the cell, and this glucose from the low concentration to high concentration goes inside of the cell, and this is a type of secondary active transportation. Now insulin is responsible for taking more glucose to the inside of the cell from the blood circulation. Okay, now when I take a lot of glucose, now insulin will be secreted by pancreas cell. Okay, now when insulin is secreted, it enhances the function of this pump, okay, of this sodium potassium pump. Why? Because this sodium potassium pump was responsible for this secondary active transportation. When I enhance the sodium potassium pump activity, so I will remove more sodium from the inside and more sodium from the outside come inside to the cell with glucose, and that's why that insulin enhances the function of sodium potassium pump. Second factor that enhances the expression of sodium potassium pump, these are thyroid hormone. Okay, thyroid hormone increases the expression of sodium potassium pump. It means it increases the amount of sodium potassium pump in cells, and it causes more basal metabolic rate, more heat production, and more metabolism. Okay, and there are some problems. For example, in hypoxia. In hypoxia, the function of sodium potassium pumps are decreased. Why? Are decreasing. Why? Because when I don't have enough oxygen, I will not have enough energy or ATP. When I don't have enough ATP, so this pump can't do its function very well, because in normal situation, in rest situation, 20 to 40% energy of a cell uses by this pump. Okay, so this was about the sodium potassium pump, and its function is so important. You know, all of you know, it's not here important for now. For example, its important function is to control the electrolyte balance and also sodium potassium balance, and sodium potassium balance is so important for transmission of the impulses in neurons or in muscles. Okay, and also it helps the cell and to maintain the osmotic pressure and so on. This is not important. Now the important part of this lecture is now an important drug affects the sodium potassium pump activity, and this drug is digoxin or digitoxin, and as a group they're called Digitalis. Let me talk about this. Now let me talk about an important class of drug which affects the sodium potassium pump, and this class of drug is called Digitalis. First of all, why this is called Digitalis? In previous time, it means around 200 years ago, there was a plant which was used by botanists or doctors for the treatment of swelling and edema. As you know, one sign and symptoms of heart failure is edema. And when this plant was used by doctors, it causes some benefits and also some goodness and improvement of edema and swelling. Okay, now because the structure of this plant was digit-like or finger-like, that's why we named this plant Digitalis. And the drug or drugs which were excreted from this plant, we named these drugs Digitalis. Okay, so here we have two important drugs in this category. One is called digoxin, and another one is called digitoxin. Okay, there are a little bit difference between digoxin and digitoxin. First, the digoxin is short acting drug and digitoxin is long acting drug. Second one, both of them are lipid soluble, but digitoxin is a little bit more lipid soluble, and both of them can cross the blood-brain barrier. Both of them use for the treatment of heart failure. Okay, and mechanism of both of them are same. So here is now also about the metabolism. The metabolism of digoxin is done by kidneys, and the metabolism of digitoxin is done by liver. Anyway, let me talk about the mechanism of digoxin. First of that I talk about the mechanism of digoxin, let me talk a little bit about the normal contraction of the heart. As you know from previous lectures, in a muscle we have sarcomeres, okay, which is made of these two Z-disc structure or proteins. During the contraction, two things come to the inside of the cell or to the cytosols. One is sodium and another one is calcium, by different ways, from the extracellular area, from the sarcoplasmic reticulum, and from different ways that I have explained it in muscle contraction. Okay, now this calcium is so important for the contraction of this muscle. Keep it in your mind that calcium is so important for the contraction of the cardiac muscles. For example, why? Because calcium binds to troponin in its important part, troponin C, and troponin C remove tropomyosin. When we remove tropomyosin, so actin binds to myosin and causes cross over each other and causes muscle contraction. And just keep it in your mind that calcium is important for the contraction of muscles. Now, after the contraction of the muscles, this calcium, this cytosolic calcium, goes out from the cytosol by two ways: by active transportation, and by secondary active transportation. By secondary active transportation, how? Here is a pump, it's called NCX or sodium calcium exchanger. This pump is responsible to bring free sodiums inside to the cell and excrete one calcium to the extracellular area. Okay, when, keep it in your mind, that's two way that calcium goes out from the inside of the cell: by active transportation and by secondary active transportation. And some part of calcium is pumped actively to the sarcoplasmic reticulum or to the endoplasmic reticulum of these muscles, and here it stores. Okay, now if I give digoxin for someone, what it do with this muscle. Okay, if I give digoxin for someone, it blocks a sodium potassium pump. It blocks a sodium potassium pump. Okay, when it blocks sodium potassium pump, I told you before that when I block sodium potassium pumps, it means I deactivated this pump which are called secondary active transportation. Now if I block sodium potassium pump, so now lot of sodium will be accumulated here inside of the cell, and this sodium can't come inside to the cell. Now this calcium can't go by this sodium calcium exchanger. So at the end of the contraction, this calcium, because it can't go outside of the cell, so it will come to the sarcoplasmic reticulum and it stores here. Okay, now during second contraction, during second stimulation, when I stimulate this cell, so calcium will come from the outside, and also during contraction more calcium is released from the intracellular, from the sarcoplasmic area to the cytosolic area, and more calcium causes more contraction of this cell, and that's why digoxin causes strong contractility of the muscles, and strong contractility is called positive inotropic action. So digoxin or digitoxin is positive inotropic drug. That's one effect on the heart. The second effect of the digoxin on the heart is that digoxin stimulates vagus system, and vagal system, or it increases vagal tone or vagal outflow. When it increases vagal tone or vagal outflow, you know that we have fibers of vagal system on AC node, and also on AV node. So when I release more acetylcholine on AV node or on AC node or AV node, it causes, vagus system causes, decreases heart rate plus decreases conduction of the stimulation from the atrium to the ventricles. So that's why digoxin is a negative chronotropic drug. It means it decreases heart rate, plus this is a negative dromotropic drug. It's a negative dromotropic drugs. It means it decreases conduction of impulses from the atriums to the ventricles. Also digoxin has its effects on gastrointestinal system. Here we have a lot of pumps on gastrointestinal system, so it causes a lot of contraction here in gastrointestinal system. Okay, and also it causes a little bit vasoconstriction. Okay, if I constructed blood vessels, so venous return to the heart is increased. Let me explain these things or effects of digoxin in a graph. This is so important. Okay, now let me talk about this. According to Laplace's law, Laplace says that put more within the ventricle, full the ventricle more. If you put more blood within the ventricle, you will get lot of cardiac output. What is cardiac output? Cardiac output is amount of blood which is pumped by the heart in 1 minute. Okay, this is called cardiac output. Now it says that if you put more within the heart, you will get more cardiac output. In this graph, for example, this amount of blood is also called endodiastolic volume. It means the amount of blood within the ventricles before the systole or at the end of diastole. Okay, so it says that, for example, this part of graph, if I go to this direction, it means I increase the in-diastolic volume, or in diastolic, it's directly proportional to in-diastolic pressure. Okay, now if I go through this direction, it means I increase cardiac output. For example, according to Laplace law, if I increase in diastolic volume, it causes more cardiac output, but under limit circumstances. It means if I increase so much here, I put a lot of diastolic volume, lot of blood, so it causes heart failure, because now sarcomeres are away from each other and they can't pump very well. But this is a normal graph of a heart. In heart failure, check it, the heart failure. For example, in heart failure, in normal heart, I have, for example, in diastolic volume about 120 ml, okay, and my stroke volume is about 70 ml, or my cardiac output is about 5 liter. What stroke volume? Amount of blood which is ejected by the heart in one beat. Anyway, so if I have 120 ml of in-diastolic volume, I should have 5 liter cardiac output, or 5.5 liter cardiac output. Okay, this is my normal point of the heart. But in heart failure, this is the graph of heart failure. This graph of heart failure shows that if I have 120 ml in diastolic volume, I should have about for example 2 liters or 3 liters cardiac output. So this is so less. Now in this time, when cardiac output decreases, it causes activation of compensatory mechanisms in our body. For example, when less blood goes to the kidney, okay, when less blood go to the kidney, so less blood, kidney says that my brother, it says for the heart that my brother, I receive less blood, please increase the blood for me. So kidney activates a mechanism which is called renin angiotensin aldosterone ADH system. And as you know, that renin system or angiotensin aldosterone system causes, first one, water and salt retention. So it causes increased blood volume. If I increase blood volume, so venous return will be more. If I increase venous return, so in diastolic volume will be more. So now my in diastolic volume goes to this direction. Okay, that's one thing. Second thing, angiotensin 2, which is made by this renin angiotensin system, angiotensin 2 causes vasoconstriction. And due to this vasoconstriction, furthermore venous return is more now. And now this in diastolic volume furthermore goes to this direction, from this direction to this direction. Okay, and also as a compensatory mechanism, when less blood goes to the baroreceptor, which is called carotid sinus. Okay, when less blood goes to the baroreceptors, it said that here is less amount of blood. It causes activation of cardiac centers. Okay, and it causes sympathetic nervous system outflow or activation. And when it causes activation of sympathetic nervous system, so it's furthermore causes vasoconstriction, plus it increases heart rate, plus it increases contractility and so on. So by this vasoconstriction, furthermore this in diastolic volume got increased. Okay, Now a heart failure patient is here. Here is more in diastolic volume, but it may be increase a little bit, for example, cardiac output, because when you put more, you will get more. So if it increase a little bit more cardiac output, now cardiac output, for example, about 3 liters. It's so dangerous. It causes slowly more heart failure. It causes hypertrophy of the heart. It causes ischemic heart disease. It causes pressure load. It causes other things. But now, if I give someone digoxin, now here, if I give someone digoxin, check it now. If I give someone digoxin, now digoxin increases contractility. Now digoxin increases contractility. When I increase contractility, I'll get more cardiac output. It's so high. I'll get, for example, it's graph. I'll get more. This is, for example, this is my normal graph, about 5.5 liter. So now, if I give someone digoxin, it causes more cardiac output because due to its contractility. Now, as time passes, kidney said that, okay, I have now blood, okay, so it deactivates a renin-angiotensin aldosterone system. When it deactivates renin-angiotensin system, so it causes less venous return. So in diastolic volume will come to this point once again, okay, and also previously sympathetic nervous system was activated. Now it's not activated. Why? Because here is enough blood. So due to this reason, due to less sympathetic activity, vasoconstriction is less, and once again this venous return is less, and in diastolic volume is less. And now if I give someone digoxin, now this is the good pointer. This is the good pointer for digoxin, that now I have less in diastolic volume plus more cardiac output. It's not up to the normal. It's not up to the normal, but it's near to the normal. And this is the beauty of digoxin. So in a nutshell, that digoxin increases contractility. It increases cardiac output. It increases perfusion, okay, of the tissues, but it's not a good drug now, because it's not first line drug. We use it at the end stage or for the emergency situation. Now we use for the heart failure, for example, calcium channel blockers, diuretics, and so on. Why we don't use digoxin? Because its therapeutic window is so narrow. It causes severe toxicity if I give a little bit more dose to a patient, okay? So what are the adverse effects or toxicity of digoxin? First one, it has toxicity on the heart. Why? You know, digoxin causes vagal activation, and it causes vagal activity. Due to vagal activation, for example, this is ECG graph here. This is PVIV due to atrial contraction. This QRS complex due to ventricular contraction. This is TVIV due to ventricular repolarization. This segment is called PR segment. This segment is called PR segment, and you know from previous lectures that PR segment is due to conduction passing from the atrium to the ventricle. It is due to avenodepolarization, and when I stimulate vagus release a lot of acetylcholine on AV node, and more acetylcholine decreases the stimulation of AV node, and it slows down the conduction because it's negative dromotropic. So it causes prolonged, this is abnormal graph, yeah, this is normal. It causes prolonged PR interval, okay, that's one toxicity. In some time it causes hard block. It means it blocks this even nodes in different degrees, first degree, second degree, and sometimes complete hard block. Okay, so that's one side effect of digoxin. Second side effect of digoxin, that it increases systole, and due to this reason it decreases this this is called QT interval from the QT interval from the start of Q wave to the end of T wave. This is called QT interval, and it causes shortening of QT interval, and sometimes it causes ST segment depression or scoped ST segment or T wave abnormalities. Okay, so this one toxicity that it causes heart block. Second toxicity on heart, it causes, first one, heart block. Second toxicity of digoxin is that it causes arrhythmias. It causes arrhythmia. As you know, we use digoxin for two purposes. One for heart failure, two for arrhythmias. Why? Because if someone has atrial fibrillation or atrial flutter, it means that the heart rate in atrium is so more, it's about 250 or 350 times. So if I give digoxin for this patient, it decreases this conduction of AV node, and this arrhythmia or atrial flutter or fibrillation can passes easily from this AV node to the ventricles, and it can't causes ventricular tachyarrhythmia. Okay, that's why I use it as anti-arrhythmic drug, but only for the atrial anti-arrhythmic drugs. Anyway, so it causes heart block and it causes arrhythmia. One side effect of this drug is also arrhythmia, because it loads a lot of cations or calcium within the cell, and it causes to increase this resting membrane potential and causes arrhythmias. Okay, that's one side effect. Second side effect of this digoxin is it causes imbalance of electrolytes, especially of potassium. As you know, when we have a patient with heart failure, he should use diuretics. Okay, so in diuretics, especially loop diuretics for furosemide, it causes hypokalemia. Okay, so hypokalemia causes toxicity of this digoxin. Okay, so keep it in your mind that it causes some electrolyte imbalance, and also because it affects gastrointestinal system. Why? Because it due to vagal tone, due to increased vagal tone or due to vagus stimulation, it affects gastrointestinal system. So it causes nausea, it causes vomiting, it causes diarrhea, and so on. Okay, and also because it crosses blood-brain barrier, so it causes some toxicity of CNS on central nervous system. It causes delirium, and it causes also dizziness, some other side effects, visual effect, side effects, and other side effects of CNS. So this was side effects of this digoxin. Don't forget that we use digoxin for two purposes: as antiarrhythmic drug and as heart failure, especially for left ventricular heart failure, not for others. So it's contraindicated in some condition. For example, don't give it with the patient who has hypokalemia. Okay, number two, don't give it in renal and hepatic impairments, okay, or failure, and don't give it to thyrotoxicosis patient. Why? Because thyrotoxicosis increases the sensitivity of the sodium potassium pumps to the digoxin, and also Don't give in myocardial infarction or severe myocardial infarction, especially in this time that causes arrhythmia, okay? And also don't give it in partial heart block. Why? Because it changes the partial heart block to complete heart block. So don't give it in this time. Don't give it in Wolff-Parkinson-White syndrome. Why? Because in Wolff-Parkinson-White syndrome we have an accessory pathway, okay? When you block this AV node, so accessory pathway or increase in it causes ventricular arrhythmia. So don't give it in this condition. And also don't give it with some drugs. For example, be careful when you use diuretics. You use some other drugs, for example, quinidine, verapamil, and also captopril, and amiodarone, and so on. So be careful with this. Okay, if I have a patient with toxicity of digoxin, so what I can do for this toxic patient? First of all, discontinue the drug, stop the drug injection or tablets and so on, okay? Secondly, monitor the patient carefully step by step. So continue your monitoring of patient, especially vital signs of the patient. Then check the electrolyte balance, okay, and if there is imbalance of electrolytes, so correct it, okay? And also if a patient has arrhythmia due to digoxin, so use antiarrhythmic drugs and correct this arrhythmia of the patients. And also you can do some things for its absorption and give him or her active charcoals to prevent from its absorption, from its more absorption. And also I have a beautiful antibody for it. For example, you know that an antibody has two parts. Its head part, which is called fragment antigen binding or FEB portion, and its tail part, which is called FC portion or fragment crystallizable portion. FEB portion is responsible for binding to antigen, and C portion is responsible for activation of immune system or complement system. So this digibind antibodies, they don't contain this FC portion. So if I give this antibody for some patient, so it causes neutralization of this antigens or these digoxin drugs. And also check the sign and symptoms and treat them. So this was a huge lecture about cell membrane transportation, and I hope you have learned a lot about today's lecture, especially about two things: osmosis and sodium potassium pump. So have a good